And our third plenary speaker this morning is Dr. Dina Goldwater. She's a clinical instructor here at the Geffen School of Medicine at UCLA. She has joint appointments both in the divisions of geriatrics and cardiology, and has also established a geriatric cardiology outpatient clinic here at UCLA that I've also personally found very helpful for many of my patients. Dr. Goldwater's research is focused on patient prioritized goal-directed care in heart disease, as well as the relationship between emotional and physical stress, inflammation, and atherosclerosis. She completed both MD and PhD training, as well as internal medicine residency and fellowships in cardiovascular and geriatric medicine at the Icahn School of Medicine at Mount Sinai. Thank you, Dr. Goldwater.
Okay, perfect, thanks. Hi. Thanks, John, for the introduction. Thanks, Mr. Ambrose, for supporting this great day. I feel very lucky to be here, to be able to talk to you about this exciting work that we're doing here at UCLA. So as John mentioned, I am trained in both geriatrics and cardiology, and I practice something called, is this the only mic that works, or can I walk? Don't walk. Okay. So I practice something called geriatric cardiology, and when I was in training, when I was telling some of my more senior, no pun intended, cardiologists that I wanted to also look into geriatric training, they said, why would you do that? All of my patients are over age 65 and they all have cardiac disease, so I practice geriatric cardiology all the time. And the truth is they're sort of right? So to be considered geriatric, you have to be over age 65, and the majority of people who are over age 65 have some sort of cardiovascular disease. But the real truth is they're not practicing geriatric cardiology, because what we try and do is we try to practice cardiovascular medicine in relation to aging, meaning we take geriatric principles and we apply them to cardiovascular care. So I'm often asking patients about things that are geriatric syndromes like frailty, which is something that we're going to talk a lot about today, or cognitive impairment or falls. I'm also really interested in their quality of life. Survival is really important, but in the age group that I'm taking care of, quality of life is often a priority. And then we're trying to design management plans in order to work with patients to reach their both health goals and their life goals. So it's a little bit of a different approach to practicing cardiovascular medicine. And the reason I'm so excited to be here today is that we're taking this geriatric focus, and it's not just in the subspecialty of cardiology, but we're starting to expand it into lots of other subspecialties. So we're going to talk today about how we're going to use geriatric principles in pulmonary disease and in renal disease. And I'm so excited to be part of this project and happy to share it with you. So we are going to talk about using geriatric assessments to improve care and optimize outcomes for older adults. The focus of the talk is on one geriatric syndrome in particular called frailty, which we'll get into. The objectives are to define the concept of frailty, examine different measures of frailty. We're also going to talk specifically about frailty prevalence in the lung transplant population, and then we're going to talk about future directions of research. It's a lot of objectives in 15 minutes, but we'll see if we can do it. So, what is frailty? The definition of frailty is a syndrome of decreased physiologic reserve leading to an increased vulnerability to stressors. I think that is a lot of words that we're going to break down a little bit more in a second. The reason why frailty is important is that if patients are diagnosed with frailty or are considered frail, they have an increased risk for a lot of things that are maybe not so good, such as a risk for debility, a risk for hospitalization. They can sometimes stay longer in the hospital if they do become hospitalized. They've increased mortality, and they have poor procedural outcomes, which is which is particularly important to what we're talking about today. But a syndrome of decreased physiologic reserve leading to an increased vulnerability to stressors. I've struggled with ways to explain it, and recently I came across this great metaphor that I didn't come up with. Some very smart folks at Duke did, Helen Whitson and Ken Schmader and others, talking about frailty in the setting of resilience and vulnerability. So if you think about a castle under attack, this is a stressor that the castle has to undergo. And the castle does not want to fall to this attack of an invading army. But this castle on the right here, it looks a little bit more susceptible to an invading army than, say, this very strong castle on the left. The castle on the right we could consider maybe being a frail castle. It has a collection of deficits. It's not just one. There are a number of things which are probably going to make this castle a little bit more likely to fall in an attack. The structural integrity of its walls are falling down. The moat is not quite as good as the other castle. Perhaps the door isn't reinforced. Maybe it doesn't even have a door. And it certainly doesn't have a really big army behind those walls that are going to shoot arrows at the invading army. Now, if you compare that to this castle over here, this castle that's very, very resilient, it looks structurally intact. It's got a nice moat. It probably has a great army inside to protect it. The thing, though, about resilience and vulnerability, if we're saying that this one is clearly frail and clearly vulnerable to attack, is that there's a spectrum. So of all the castles out there, there are going to be a lot that fall somewhere in between the great and the weak. And our challenge here when we're talking about frailty or this collection of deficits is to identify what are the components that really make it so that this castle will be resilient, or the components that really will make it so that this castle will be more vulnerable to bad outcomes. So is it just the fact that the walls are falling down, or is it more important that the moat is smaller, or is it more important that the army is smaller? So what is the collection of deficits that make the spectrum of vulnerability? So if we take that metaphor and we bring it back out to humans and we say, okay, what are the collection of deficits that perhaps make humans more vulnerable to adverse outcomes after experiencing a stressor? And when I say stressor, I mean something like an infection or a surgical procedure. And there's been a lot of work done, and people talk about what frailty means and this vulnerability, and they've come up with a bunch of domains. So the domains so far are weight loss, fatigue, low physical activity, a slowness of movement, a weakness, a muscle weakness. Some of the domains also include cognitive impairment. Sometimes they're including depression. There's a lot of emerging research right now saying that there are potentially biomarkers, meaning things that we can measure in people's blood that says that that patient may be more susceptible. And perhaps there are things that we can see on imaging, like CAT scans, like sarcopenia, or the size of people's muscles. Maybe those things are indicative of frailty or weakness. But one of the question is, what is the combination of these factors that is the most important to tell us that these patients are the weakest? Or alternatively, what's the combination of these factors that if they don't exist, those patients will be the strongest and most resilient? And the truth is, we don't actually know. There are a lot of different frailty measures that have been designed so far over the past 3 or 4 decades. The two most commonly used are Fried's frailty phenotype and the short physical performance battery, but there are a host of others. They're all different, and they all use a different combination of these domains. So when we're looking at the patient in front of us, we want to understand what is the collection of deficits that make this patient more vulnerable to adverse outcomes so that we can address those issues along the way. We don't know. And I think that what's most important here is that not only do we not know what combination of these deficits is the most important, but it's possible that depending on what kind of disease the patient has, the combination of deficits will be different. So the combination of deficits that are most important in frailty as people get older may be different than the frailty that happens when people have advanced heart disease. So when people age in the community, about 20% of people are frail, 20% of people who are over age 65. In heart failure, if you have advanced heart failure, about 60% of those patients are frail. So we don't know if that frailty is the same as the frailty of aging, or if it's different. Like I said, what combination of these factors are the most important things for us to know about? So as we move forward and we start bringing these geriatric principles into the subspecialties, these are the things that we need to start to investigate. So I'm going to tell you about a study of frailty assessments that we're doing prior to solid organ transplant. And I was lucky enough to be brought into this incredible project that was initiated by Reshma Binwali, who is a cardiothoracic surgeon here at UCLA, and Joanna Shainman and Eugene De Pasquale. They brought me in to help on the frailty assessment part of this study. Today, we're going to be talking mostly about, in fact, only about patients who are undergoing lung transplant, because we have some very preliminary but also sort of interesting data to share on what frailty looks like in this cohort of patients. So why is it important to start to study frailty in patients who are undergoing lung transplant, or any transplant for that matter? Well, the fact is that over the years, the age of patients who are undergoing transplants has increased dramatically. In 1987, the average age for lung transplant was about 36 years old, but in 2014, the average age is 60. So that means that half of the patients are older than 60. So things that happen, the frailty becomes a really important assessment in this population, because we think that the current way that we're judging whether or not people are good recipients of lung transplants is something called the lung allocation score, or the LAS. But the LAS doesn't really take into account some of these geriatric syndromes that we're talking about. So patients who have, who experience some of these geriatric syndromes, they're not captured by the LAS score, and perhaps if they get a lung, they will still have an adverse outcome, and therefore we're not distributing organs in the best way to maximize their utility. So what we need is new predictors of post-transplant survival and health-related quality of life in this population and in all transplant populations. I want to give a special thanks to Joanna Shainman for sharing some of her slides with me. You'll see the ones that are down here in the corner. So this study is called the Frailty Assessment Study in Transplantation, or Lung FAST-L. The bigger goals, so we're going to talk about a very, very, very small portion of it, and like I said, the results are incredibly preliminary, but the large goal of this study is to look at the effects of frailty on post-transplant outcomes. But we're also interested in sarcopenia, and that's something that we see on imaging, and this part of the study is being headed by Kathleen Ruchowski in our radiology department. And then we're also interested in biomarkers of frailty, or biomarkers of vulnerability in immune senescence, and this is being headed by Joanna Shainman. But right now we're just going to talk about the frailty component of it. So who are the patients that we're evaluating? We are looking at patients who are being evaluated for lung transplant. The inclusion criteria for the study are patients who are over 60 years old coming in for evaluation. They must have end-stage lung disease because they're being looked at for transplant. They're excluded if their age is below 60, and they're also excluded if when the pulmonary team sees them and they deem them not an appropriate candidate for transplant. So we're only looking at people who will hope to eventually progress through transplant and thereafter. The study design is that we meet them on the initial visit and we do frailty assessments. We have some incredible research assistants who are incredibly hardworking, and they show up at the lung transplant clinic and they do the assessments on these patients who are being evaluated. They actually have a poster today. I recommend you stop by and see it, because they'll give you more in-depth detail about some of the things that we're talking about today. So initial visit, we have frailty measures assessed, and then Ultimately, the patients will undergo a lung transplant. And then we're looking at post-operative measures. We're going to be measuring frailty post-operatively, and we're also going to be looking at things like post-operative 1-year survival and quality of life, et cetera. So what are the frailty measures we're looking at? Like I said, there are a lot of frailty measures we could possibly use. We're using 2 of the most common ones. One is called the Freed Frailty Score, and the other is called the Short Physical Performance Battery. So Freed Frailty is made up of 5 components. One is weight loss, one is fatigue, one is low physical activity, weakness as measured by grip strength, and slowness as measured by gait speed. It's important to note that while weakness and slowness are objective measures, we're actually having the patient perform these tests. These are self-report. The first 3 are self-report. So we ask the patient, have you lost 10 pounds in a year? We ask them, in the last 2 weeks, has everything you've done felt like an effort? Yes or no? And then we ask them to tell us how much physical activity they're doing at home, and we'll calculate kilocalories of energy expenditure. And we're interested in things that are exercise, so walking, running, biking, bowling, whatever people like to do. So on the Freed Frailty Score, if they have 3 out of 5 criteria, then they are considered frail in this scoring system. The next scoring system we're looking at is the Short Physical Performance Battery. This is 4 objective measures of physical performance. So we're looking at balance, weakness, and slowness. Note that gait speed is consistent in both of these, right? We're using the same gait speed across both measures. The weakness is not the grip strength here. We're asking the patients to stand up and down 5 times in a chair, from a chair, and we're timing them. And based on their time, we have certain cutoffs for weakness. And then the balance is a side-by-side stand, like this. And then they have to hold that for 10 seconds. And a semi-tandem stand, hold that for 10 seconds. And then we want a full tandem stand and hold that for 10 seconds. This is scored out of 12 points. Each one of these can be on a scale of 0 to 4, so total of 12. Higher scores are better, and more than 10 makes patients non-frail. All right. So we have those 2 different frailty measures, and we're evaluating these people who are coming in pre-transplant. The number of patients so far that we've evaluated in the lung transplant group is 21. The average age is 66 years old. 57% are male. The majority are white, and the majority of the reasons why they're in end-stage lung disease is something called idiopathic pulmonary fibrosis. 21 patients underwent the SPPB frailty measure, and 14 of those 21 ended up having the Freed's frailty. We started doing a slightly different frailty measure partway through, and that's why only 14 have the full Freed's at this point. Data collection continues and is ongoing. So when we look at frailty prevalence in this population just at baseline, when they're coming in for their initial assessment, what do we see? In using Freed's criteria, that's the one where there's the self-report of weight loss, physical activity, and exhaustion, and the 2 measures of strength and walk speed. 60% of patients who are coming in being evaluated for lung transplant are considered frail. So the majority of patients are considered frail. 40% are pre-frail, and none are not frail. But then you take those exact same patients and you measure their frailty based on the Short Physical Performance Battery, and we see something very interesting. So based on the Short Physical Performance Battery, the majority of patients are actually non-frail. So the lines didn't work out, but the numbers are close to 50% of patients who are coming in for this evaluation pre-lung transplant are not frail. 30% are pre-frail, and I think about 10 or 15% are actually frail. So that's really interesting. What does it mean? Which one of these scores is going to be more predictive in this population? And we don't know the answer to that yet. But that is certainly something that we're looking into. Another thing that we want to know is what's the correlation? So are the people who are frail in Freed's frailty, are they also frail by SPPB, or is the data all over the map? And it turns out the data is sort of all over the map. Of Of the 14 patients who had both, only 3 patients were categorized the same by these 2 frailty measures, whereas the rest of them were not. Another way to say that is that there is not a very strong correlation between Fried's frailty and the SPPB. The R-squared here is 0.16, which is surprisingly low, particularly because one of the criteria is the same in these 2 measures. So we would expect the correlation to be much stronger. Obviously, this is very preliminary. I don't know if this is going to hold up when we get more data, but it certainly is an interesting question. So is frailty correlated with anything? And we looked at whether Fried's frailty score was correlated to age. And we saw another thing that was very interesting. So what we saw is that as patients get older, their frailty scores are better. So the 70-year-old patients that are coming for evaluation for lung transplant are actually less frail than the younger patients. And if we take a second to think about why that may be, is think about the pulmonologist in the community who is referring their patients for evaluation for lung transplant. If they have 2 70-year-olds sitting in front of them, they're going to refer the 70-year-old who's playing tennis once a week, and they're not going to refer the 70-year-old who is in a wheelchair or dependent in some of his ADLs or is living in a nursing home. So I think this is what we call a little bit of a selection bias. It will be interesting to see if that holds up as we get more data. There is not an interesting correlation between SPPB and age just quite yet. So preliminary conclusions, again, very, very early data, but in this population of patients who are coming in for evaluation pre-lung transplant, the prevalence of frailty is highly dependent upon the frailty measure that we're using. And older age may be associated with less frailty based on the Fried's frailty criteria. Again, this all needs to be confirmed with more data. And there are many, many next steps here. And this is not even all of them. But one of the most important things is to explore the association between these frailty scores and outcomes. Is the SPPB going to tell us more than Fried's frailty, or is Fried's frailty going to tell us more? Or is one going to be more indicative of who's going to be resilient and do well versus one that's going to be more indicative of who is going to be more susceptible and vulnerable to adverse outcomes afterwards? Another thing that's important is that we want to see if there are any individual components to these frailty. Are there any individual domains that come out that are more important? Sorry, I'm over time. Okay. And then it'll be really fantastic to be able to compare findings across the solid organ transplant groups that we're working in. So like I said, we're going to be working in the heart transplant and the kidney transplant population as well. And then finally, we want to target intervention. So if we find things that are going to increase people's vulnerability, can we target them with interventions like medications or nutrition or physical therapy before patients undergo these procedures in order to make sure that they have a more robust outcome afterwards? There are a lot of people to thank. Like I said, I was brought into this project. I was not there at the beginning. Reshma Binwali and Dr. Ardahali are both cardiothoracic surgeons and initiated this project. Eugene and Joanna are the ones who brought me in. Eugene's a heart failure physician. Joanna's an infectious disease specialist. And Kathleen Ruchowski is the one who's going to be helping us with the imaging. We've got some really incredible help in the kidney transplant. Chris Lee is getting our frailty assessment in EPIC, which is exciting. And Mario Dang is another member of the heart transplant team who's going to be working with us. And last but not least, our amazing research assistants who have collected all this data. Please go see their poster. Bill, Saravya, Vishal, Luke, and Nick have done incredible work collecting all this data. So I'll stop there. Thank you very much. Are there questions? Yes.
Hi, I wanted to ask you about gene therapy. Do you think, the normal aging process, people get older, maybe gene therapy earlier, like when people are in their 50s or 60s, as opposed to waiting till they're in their 70s and 80s, can prevent or slow down the progression or the appearance of some diseases like dementia or cancer so that we don't have to deal with a lot of these issues?
I think that's a great idea, and there is a lot of work right now being done on what are the genetic predispositions to this type of frailty, what are the epigenetic predispositions to this type of frailty, and what are the interventions that we can do on if we identify those issues. That work is fairly in early stages, but there is a lot of money being put towards that right now.